you're studying cardiac and med surg too. Remember, children and adults are different in cardiac. Children don't really have myocardial infarctions, but they do go into congestive failure. But they do show different signs of assessment things that you'll see in them. And hopefully I'll cover that. Respiratory and cardiac are probably your most covered subjects when you get to the point of your NCLEX. They really like to focus on it. So I'm going to try to make it easily understandable for you, okay? So I do got a good Cahoots. It is 55 questions, and I do have a slideshow. I believe it's 60 slides. So let's get started and get that going for you. So we'll start out with respiratory. So respiratory and cardiac dysfunction. And respiratory, I think, is one of the biggest things that we see in children. What do children get? They get upper respiratory infections, which is the nose, the ears, the throat, the dripping, the cough. And then, of course, it goes lower. It can go into like pneumonias. Most infections of the upper respiratory system are viral. Rarely it is bacterial. That's why you take your children into the pediatrician, say, oh, he's a fever of 103 or 104. Viruses have big fevers, guys. The bacterials are usually 101, 102 in my experiences. I don't think it's documented, but it's what I've always seen. So viruses have big fevers. You bring your child in there. Let me see who's this trying to, let me see. Everybody muted? Okay, thank you. I was listening to a TV. The upper respiratories are mostly your viral infections. Now, you go into pediatrician, you have a big fever, 103, 104, you know, they've been there with, you know, mucus and coughing and ears hurting and feeling miserable, and you think you need an antibiotic. Well, we know viruses are not taken care of by antibiotics. Usually, you're not going to get antibiotics till after 3-4 days of going on with an upper respiratory.
Open the door.
Who is talking that I can hear them? Could you put it on mute?
Just push the door.
Oh, let me find you.
It's Diane.
Oh, you got it? You took care of it? Let me find her. Hold on. I know how annoying that could be. I'm going up and down the list. All right, I think we're good. Okay, so once we've ruled out, you know, it's not a virus, something's going on even more. Usually you're going to see more of a streptococcal, or, you know, you get into the Haemophilus influenza, which is a pretty sick kid, you know, on the pneumococcal, et cetera. And those children will be placed on your antibiotics. Now, when we're talking about children and getting infections, the thing with children is when they're born, they're literally born with just mom's immune system, but it goes away pretty quick. So these children are left to build up their own. And how do we build up their own? We build up their own by giving them those immunizations at 2, 4, 6 months. We also have these children, they are getting sick and getting these viruses, and these children are, you know, building up their own antibodies. So when you have a small child, less than 3 months, usually it's mom's maternal antibodies, but all of a sudden, between 3 to 6 months, these little infants start getting sick. It's because mom stuff's going away. So they need to build up their own. So you're going to see a higher rate of sickness. When you get to those toddler preschoolers, remember, they swap spit all the time with their in daycares and in preschools, you know, where they're always using everybody's toy. And we know oral satisfaction, you know, how do children satisfy themselves? It's by chewing, biting, sucking, right? Everything in the mouth. And they're swapping it. It's actually a good thing, because then by the time they get into their school age, their kindergarten, et cetera, they've built up their immunity. And now it's usually just the bacterial infections that they'll get, and we'll put them on the antibiotics. And we know as we get older, get more infections, our immune system does get better. Now, the reason why we get a lot of ear infections and a lot of these upper respiratories is because everything is so small, it's open, it's wide, and mucus can travel, especially into those eustachian tubes. You know, children don't know how to blow their nose, so the mucus sits in there and then it goes up into their ears. Now we're into ear infections. And that's one of the reasons why they do get those. Now, what do children look like sick? Well, usually you'll see them just with a fever. But what a child does is so different than adults. Adults get sick, they have to keep going to class, keep doing clinicals, do what you need to do because you're sick. You just take your Tylenol, Motrin, you keep going. Children will just sit down, they won't eat, and they'll, sometimes they'll even vomit, the GI symptoms to it. Once we treat the fever, like I've told you before with that cahoots about why do we give Tylenol and Motrin to fever, once we get the fever away, these kids get up and move around like they're not even sick until the fever comes back. We know they always have this cough, we have this mucus, and again, it's that rhonchi-ish type sounds, that upper respiratory bronchial breath sounds that we see because it's all up into the nose. So what is our goal? Taking care of children. Well, we want them to breathe easier and we want them to rest and be comfortable and give nutrition and hydration. That's getting that fever down, right? Teach them how to wash their hands, use tissues, which we know is always a chore, but we're still going to keep trying. And then, of course, giving them a hug, knowing that when they feel bad. So otitis media, we know it's due to those short little tubes, and it causes infection and it causes a lot of pain. How do we treat otitis media? Well, antibiotics, it is a bacterial infection in the middle ear, that you'll see the eardrum get swollen. It's painful. These kids are holding their heads. And the first thing I'll do to any child who had an ear infection was give them Tylenol or Motrin, whatever was the last one they gave. Which one can I give? I will give it right away. Sometimes little hot packs on the ear also help too. The thing with ear infections is when we start seeing a lot of them and we start seeing 3, 4, 5 a year, that's when a physician will say, well, we're having too much reoccurrence. That's when we'll go, instead of just giving antibiotics and then your antipyretics, analgesics, Tylenol, Motrin, we'll go to the surgical route. And that's when we put the tubes in, when you're having those chronic ear infections. Now, infectious mononucleosis, I never really understood that well, but working in an emergency room, read about it, saw many children about it, and it is what we call the kissing disease. They say it's spread, through oral secretion. So it's kissing with the adolescents, of course, but younger, sharing things, toys. What do? They share toys, and that's what happens. And it has to do with a sore throat. These children will complain. They'll have a fever, sore throat, and ache everywhere. Of course, those lymph nodes are big because they have an infection, right? There are no lymph nodes with no infection, but you'll see it. But also the liver and spleen, one or the other or both, will get swollen. Now, let me give you a case history of a child with infectious mononucleosis. They go to their physician, sore throat, they do a strep swab, usually a flu test too, everything's negative. They'll say it's viral, pharyngitis, Tylenol, Motrin, plenty of fluids. 5 days later, they're still sick. Many of them will go to urgent care or something. And then they'll say, all right, well, again, they'll swab, still nothing, negative. Well, let's put you on antibiotics to be sure. 7 days later, 10 days later, they'll say, this kid's still sick, still complaining of his fever, sore throat, aches and pains, antibiotics not working. Now they have vomiting and diarrhea from antibiotics. Let's go to the emergency room. So we'll hear this history, and what we'll do is we will draw blood. We will draw blood for a CBC, and we will draw blood for a mono spot test, and it will come back positive. Now, mononucleosis is extremely dangerous. And many parents don't take it to heart how dangerous it is. That spleen and liver are swollen, especially the spleen. It gets very swollen. These children cannot be in any physical activity. No PE in school, teaching the brothers and sisters not to roughhouse, no rolling around on the floor. And we're very clear with it because it can rupture. It's still a viral infection, tunnel, Motrin liquids, and it just takes time to go away. Now, I had one case, and it's a sad case. 9-year-old boy, same history, case history, exactly what I just said. Came in, he was my child on a Saturday. He came in with his father. We explained no PE, no roughhousing, protect that abdomen. He should be on rest, Tylenol, Motrin liquids until they go back like 3 weeks later, within 3 weeks, to see his pediatrician. Well, 1 week later on a Saturday, I'm trauma nurse, I'm primary nurse. We get an alert. In a child, 9-year-old male, falls off ATV and he fell on his belly. He had mono. This was my kid. By the time he got to the emergency room, he died. He ruptured his spleen. So I'm telling you, mono is actually not just kissing disease, something easy. You need to protect the belly. So nursing, we must teach them Tylenol, Motrin, it's a virus, plenty of liquids, a lot of rest, and protect that belly for everything, because as I just showed you, they can die from it. All right, then we have croup. Croup is something to do with barking, respiratory distress. It's the larynx, the trachea, the bronchi, and there's different sort of croups, different variations. It is inspiratory stridor, and you're going to hear barking like a seal and many of those things. It can go to the point of epiglottitis. Now, epiglottitis, we know the epiglottis is that leaf-like structure that covers the trachea when we swallow food, so food doesn't go down the trachea and cause aspiration pneumonia. Well, it swells so much, it goes over the trachea and you can't breathe. These children, literally, they have to move their head around, lean forward, and get in a position that one little piece of air can be moving. They cannot swallow. They'll be drooling, severe respiratory distress. They'll see them almost in that tripod position. And these children, it's a medical emergency. These children need epinephrine in an aerosol, in a shot, start an IV. They need steroids, and it's a very serious thing. Now, laryngotracheal bronchitis is a swelling of the area. Air still moves in there, and these children need steroids. So epiglottitis, medical emergency. I've only seen one in my whole career. They're going to be leaning forward, tripoding, drooling. They can't swallow. They're going to be in distress. So we need to be prepared in case it gets to the point that swelling covers that whole trachea. We need an airway, because airway is number one. So you're going to probably do an emergency intubation, but can you get that tube down that swollen epiglottis? Probably not. So it's probably going to end up to be a trach. Thank goodness the one case I saw, we were able to medically manage it with the steroids and the racemic epi aerosol and a shot of epinephrine, and it really getting the IV in. But this is dangerous. As I said, acute laryngotracheal bronchitis is children less than 5 years old, and it can be called RSV. Usually RSV, we call RSV for the small children. And the older children, it is laryngotracheal bronchitis. And again, it's a virus, so it's not antibiotic. How do we treat this? Well, we might give a saline aerosol, but the biggest thing is to give steroid. And the steroid depends on your physician. It could be one shot of Decadron, or if the child is, doing okay and breathing, we might just put them on some prednisolone, oral steroids. Could be twice a day, 3 days, 5 days, depending on physicians. It really doesn't matter. Now, RSV is respiratory syncytial. It is a virus, common cold for you and me, but in little tiny children, like less than a year old, especially less than 6 months, it creates a lot of mucus. So it's hard for a child to suck, swallow, and breathe. That's just feeding and breathing, very hard. Put mucus in there and they can't, and they go into respiratory distress. Then put on top of it some sort of problem, cardiac problem, or let's say cystic fibrosis or prematurity with lungs that are already having issues, it can be a big deal. So RSV in the small children, we can give them an immunization, especially those children who are immunosuppressed, like the cardiac, cystic premature children that I've already said. And we usually give it during that RSV season, 5-6 months, they give it, and it's monthly vaccine to prevent them from getting it because they're already compromised. You don't need to compromise their respiratory system too. So usually your laryngotracheal bronchitis, you've got an upper respiratory problem. You're going to see the stridor, you're going to see retractions, and then you're going to hear them barking from a mile away. It's very, very distinguishable. You'll hear it. The thing, it's really not a dangerous thing, but it can go into respiratory failure if it's not treated. Many of these children, the parents, this bark, they get very nervous. And many times we're going to hear it at night. A lot of times these children come in the nighttime. And many of them, when they come in, they're not barking as much. And the parents said, but they were really coughing a lot. It's the change of air conditioning, going outside, back into air conditioning. Those environmental changes change the tone of the cough. And we say, we believe you. And then we'll give them either the shot of steroid or the oral one. So what is our goal with anything airway? Of course, we want the airway to be open and working. We want to make sure that they're hydrated, whether can they take it orally? Now, epiglottitis, there's no way you're going to put anything in that mouth because there's nothing going down. So that would be that child who gets IV. We're going to give that mist, that saline mist, okay, because the moisture helps. And we're going to give oxygen to relieve any hypoxemia and just to prevent it. As I said, we're going to give epinephrine, racemic epi aerosols, and we'll give steroids to get that swelling down and having them breathing better. As I said, RSV, this is what we need to know about RSV is the immunization. And this immunization is called Synergist. It is on your matching list. It's one of those medicines that you need to know. We give this to children who are premature, are cardiac, or are other conditions that they don't need to have respiratory distress as part of it. And it's 5 or 6 months that they call it the season. I mean, in Florida, there's really not that season like up north, but the fall to spring, that season is usually when we'll be giving this RSV, we'll be giving the Synergist injections, and it is monthly. Pneumonias. Pneumonias are that lower area of consolidation in any lobe of the lung or multiple lobes of the lung. You have a child who comes in, fever, cough, and vomit. Usually you're going to say it's a pneumonia. It's just, you would look at the child and see that they're not breathing well, and you can see they have a fever. Listening to their breath sounds, you'll hear one or multiple lobes that you hear decreased or no breath sounds. And we know that in pneumonia, it's supportive care. What are we going to do? They need oxygen, we're going to give it. If they need IVs because they can't breathe that well, we'll give IVs. These children, pneumonias are bacterial, we'll be giving antibiotics. Sometimes we give one, sometimes we give 2 different types, negative, positive germs, or just one that covers both. It depends again on physicians, but they need antibiotics. Now, as I said, most of them are bacterial pneumonias. Rarely do we consider them viral. We have the mycoplasma, that's your double antibiotics, pneumococcal, but we've got that vaccine now, which we can give to the younger children to help prevent it because that's one of the most dangerous types of pneumonias. Remember, pneumonia can also be aspirational. So making sure powders and very toxic substances, cleaning the bathroom with the bleach, etc., keep the kids out because it can burn the lungs. It can burn your lungs too. I've had students come to me that they clean their bathrooms and they burnt their lungs with the bleach and whatnot. I said, basically, you've got an aspiration pneumonia. And they say, yeah. And, they're coughing, coughing, coughing because of the irritation. Now, pertussis is not really too many cases because we have a vaccination for it today. It's extremely contagious. Now, it doesn't mean it's completely wiped out because not every child gets fully immunized. There are some parents who still don't believe in immunizing their children, and that's their choice. But it can cause other children to get it even when immunized, just like you can still get the flu even with a flu shot. It's the same thing. We had a big case here a couple of years back in this county and the one county up. These children are very sick. These children are all respiratory. What's going on is also called the whooping cough. And these children, if admitted to the hospital, have to be in an isolation of reverse flow, which means the air from their room can't go to the population. It has to be filtered within their own room to keep it safe. And all healthcare providers must wear masks. Another thing kids love to do is they love to swallow things. And believe it or not, when they swallow a coin, it's not a penny or a dime. It is always, I've never seen anything less than a quarter. They like the big one to go in. And you see that picture right there? I've seen that over and over again. So what do you see? You see the little child who's like spitting, gagging, choking, and it hurts. And they come in and we do an x-ray, and I let them see the x-ray and say, gee, you got a quarter in there. When it comes out, can I have it? So now we've made some fun with it. What they do and how they get this out, they used to go in to the OR and do a bronch and little clips and pull it out. But that requires sedation, IVs, OR, overnight. What they do today is put actually a Foley catheter with a big balloon, and they put it down the throat, below the area, below the balloon, on the surgeon's lap. Usually they pull them forward and pull it out, and they usually vomit some mucus up, and the coin comes up too. And it's actually, they go home later. We watch them a little bit, make sure their airway's okay, and it's fine. Now, I have seen a French fry that was aspirated, and it was this little boy was at the clubhouse with his grandma and had a French fry, and all of a sudden choked, and they tried Heimlich's and couldn't get it out, and they got rescue and brought him over, and it lodged, and it really obstructed the airway. The child ended up on ECMO, a machine to breathe for the child. And from a French fry, this kid about 4 days later did die from aspiration of a French fry. So 1 to 3 year olds having a French fry, this is cut up in little pieces. I mean, I know we give it to them. They love McDonald's French fries, but I'm just saying things like that can happen. I've seen beads, paper clips, things in the nose, in the ears, in the mouth. I've seen them all over the place. But the coins, it's usually the quarter. As I said, aspiration pneumonia. Again, today, be careful. I used to love using baby powder. I think Johnson & Johnson baby powder smells good, but it's really not good for the kids' lungs anymore. So the air, they inhale it, and it can hurt their lungs. And it can really hurt them. Also remember, there's something called reflux. Infants get reflux. And if they're refluxing, they also can have what we call aspiration pneumonia for the feeds going in. And we prevent that by frequent burping, sitting them up afterwards. And sometimes to prevent reflux, we put a little bit of rice cereal into the formula. And it has nothing to do with nutrition, because you'll see the rice cereal in the stool, but it thickens it and it holds it down and prevents that reflux. ARDS, acute respiratory distress syndrome, has to be due to an acute lung injury. It could be due to drowning. It could be due to sepsis, trauma, and as the older children, drug overdoses. Now, one of the things with near drowning, remember, I live in Homestead. I live in South Florida, and we have a lot of pools, and we have, the ocean here, and children do have these near drowning. Many times you go and get these children, the rescue goes, and the kid's already up out of the pool. They revived him and they're running around and they think everything's good. It can happen 72 hours after the initial drowning that they can go into respiratory distress syndrome. These children will be brought to the hospital, will be admitted in a monitored area, usually an ICU or ICU step down on a SAP monitor, because they can go downhill really quick within 72 hours. That's quite a long period of time to watch those children. We could predict it more with trauma, sepsis, but the drowning is the one parents, but the kid's fine, he's running, it's fine, I don't need you. And then you have to explain it still can happen. So in acute respiratory distress syndrome, this is a child whose lungs are really hurt. It could have been that drowning, could be overwhelming sepsis, it could be traumas from pneumos, etc. These children are sick. These children will be intubated, and it takes a long time to heal those lungs. Many times they end up like that French fry kid with injury due to an ingestion, that this kid ended up on ECMO, which is a machine that takes blood out of the body, it oxygenates it, and it puts it back in the body because the lungs cannot work. And they are intubated on low settings just to keep the lungs and let them heal. So it is a condition with a high mortality rate, even with all that. Most common of all respiratory conditions in children is asthma. I think all of you have had asthma, still have asthma, know people with asthma. It is basically a hyper responsiveness to some sort of antigen, and it swells and it causes an obstruction. And many times when they're having this asthma attack, they're short of breath. And what is our initial treatment? Well, we have a rescue. And our rescue is that little inhaler, albuterol, Proventil, whatever the names, it's a tries to dilate the lungs. Now, one of the things with using these little inhalers, you hear a parent say, they used it 4 times and it didn't work. Well, did they do it right? Because children, can you push it and inhale it? There are adults that can't do that. So there are these little spacers, and you see them on the bottom, from infant to adults, that we put them on, squirt whatever the dose is, breathe in and out 4 or 5 times, and you got the whole dose, okay? So making sure that they use the whole dose. And if they're using it 4 times, there's still something wrong. They need to have other things done. Now, once you've been told you have asthma, there are things that need to be done to try to help prevent them, because we want these children to be absolutely normal, and we want to prevent any exacerbations of them. Not being able to breathe is very, very hard. My husband was in ICU 12 days with status asthmaticus, and I know what it looks like. I know what it sounds like. And thank God I had physicians and nurses who did not kick me out because I kept my husband calm. I was one of those who was like, can we try aminophylline now? Can we try this now? Or how about if we did it? If I was a part of the care, which made me feel pretty good because I sort of know what I was doing. But anyway, so now we've got the child diagnosed. We need to do pulmonary function tests when they're doing well. There are these peak and expiratory meters that we can bring home now, the parents, and we can test these children daily. So we get a test when they're doing normal. We can see how much they're blowing. When we're doing it daily or we see a cough, we see that volume decreasing, we know we have to increase aerosols. We know we need to do something before it becomes status asthmaticus. So pulmonary function, and then something caused it. There was an allergen. Is it a cat? Is it a dog? Is it a mold? Is it a tree? Is it grass? What is it? And then if you've got a kid with allergens to grass, this child shouldn't be playing sports like soccer, because that can exacerbate that. Maybe this kid can be playing tennis or swimming or bowling or something else that doesn't have that much grass. So long-term control medicine, these are your things like Symbicort, Brio. They have a little bit of steroids in them, and these are twice a day. Children, what they use is something called Pulmicort, levoalbuterol. It's not albuterol, it's levoalbuterol, which is has to do with a little bit of steroid in it, Pulmicort. And this is to prevent it, to keep those lungs safe. Of course, we have rescues for when they need it, and then corticosteroids when we need it. And then, of course, with that good old Singulair, which is like a Claritin, but specific for lungs and the allergens, and to keep those lungs from being hyperactive. So that's a little bit about your respiratory stuff that's going on. I have a lot more stuff in the Cahoots, which is going to show you a lot more signs and symptoms, which helps you understand more. So now probably the hardest of all things for students is cardiovascular dysfunction in children. You know, adults are a little bit easier. Children, oh my goodness. So if anybody needs a one-to-one who don't understand this, I'd be more than willing. Or if you have a group of you who want me to explain it more, please ask me. I will be more than glad to go over it. But let's start. So 2 types of cardiac defects, one that you're born with called congenital. That means the heart wasn't formed right during that forming process intrautero, or it could be something that was acquired. Viral infections causes viral cardiomyopathies, big swollen floppy heart, or autoimmune. Think about lupus. Lupus affects the heart, right? Or it could be environmental, it could be around, you know, chemical plants, etc. Well, sometimes it's due to familiar tendencies, sort of congenital. Now, the one thing you need to understand is blood flow through the heart. If you don't remember it, think about it. Let me just go over it quickly. Think about the heart and how it pumps and how blood, let's go leaving the heart and coming back to the heart, okay? Because when it leaves the heart, it's that big muscle, it's that cardiac pump, it's that engine. So blood flow goes out quick. It goes from the left ventricle through the aorta, aortic arch, goes all the way through the body. It comes up the inferior vena cava, superior vena cava, and now it ends. So it's less blood flow entering the right atrium. So left side of the heart has more force flow than right side because it just ends into the right atrium. Goes through the tricuspid valve, into the right ventricle, goes up the pulmonary valve, it goes into the lungs, comes back to the left atrium. There's actually 4 pulmonary veins. I always thought it was 1, but it's 4. Goes into the left atrium, through the mitral valve to the left ventricle. So if something happens to this heart, now we know that left ventricle pumps and it goes out the aorta. Let me tell you one of the diagnoses, and I'm going to show you what it is, like a garden hose, okay? So the aorta is a garden hose. Let's say at that arrow below that lung there, it's got a kink, it's got a narrowing. That means blood can't go down there. Where is it going to go? Well, when you kink a hose, where does it go? It goes backwards. So it's going to go into the left ventricle and swell up left atrium. Where's it going to end up? A big pooling spot is that lungs. So if you had a kink in that aorta, you might see lungs filling up, and you're going to see signs of congestive failure, shortness of breath, decreased breath sounds, right? Another thing you're going to see is that blood flow can't get down to the toes, right? So it's going to be decreased pulses down there, also decreased blood pressure because it can't get down there, right? Now, what's going to happen to the upper one? The pressure is going to be higher. A lot of times, coarctations are not always caught at birth. And that blood flow goes back, and you could see the 3 branches going up to the head. You might see nosebleeds, headaches as they get older. You also, the flow on the upper extremities to the arms, higher blood pressures up top because blood flows up there because it can't get down, and then lower blood pressures on the bottom. So you've just learned your first diagnosis, congenital heart defect called coarctation of the aorta. All it is a kink. Garden hose goes back. Signs and symptoms, just like congestive failure. the lungs fill up with all that extra blood. It's the filling spot. It's the place it will go. Goes to the place of least resistance. So sometimes they're not diagnosed immediately at birth. If we're feeling there's no pulses in the lower extremities, we'll go, oh, coarctation, easy. But what if, little pulses are there, or it wasn't felt, maybe it slipped through the cracks. Those things happen too. You are going to see an infant. And I had a little girl at 3 months old, came in exactly what was going on here. Couldn't feed, short of breath, tachypnic, tachycardic, not gaining weight because they're not eating good. I mean, they would, take a bottle or nurse, whatever they were feeding, a little bit and stop. Because of that, they're not going across the developmental sequential trends the way they should, because they're not getting nutrition. Cognition was decreasing. Sometimes you might see it because of mom, or maybe you know about it, or a family history, but sometimes all you get is these symptoms right there. So what's the next thing we do? We hear those things, we're going to inspect that child. Well, nutritional status, the kid's 3 months old, was born at 7 pounds, and they weigh 7.5. There's a problem. This kid should be at least 9 pounds by now. So something's happening. Color, easy. We could see this little infant here. You can see the purple on the lips. Probably look at the fingers. We're going to see some purpleness, or we're going to hear a murmur in the heart. Shouldn't hear that murmur like that. Or maybe no pulses, or higher blood pressures on top, lower on the bottom. And we're going to see, as they get older, the clubbing of fingers. We don't see that in infants. It's as they go on in the cardiac. When we look at the heart, so we have a child who has some sort of congenital heart defect, and there's many of them, and I'm going to go into that next. We know coarctation already because it's a good example of showing you the garden hose, but we're going to see the chest. It's going to probably, be bounding. Sometimes you can put your hand on it. You can feel murmurs pulsating on it. You'll see abdominal breathing. You're going to check. That's why in cardiac, we do 4 extremity blood pressures to make sure, is the blood flowing the way it should. With coarctation, there's at least 20 points of mercury higher up top than there is lower. If the kid's getting to the point of being in congestive failure, filling the lungs up, what's going to happen to that heart rate? It's going to go up because you can't oxygenate because it's full of fluid. We can't oxygenate that well. And again, is there a murmur? Is there a regular heart rate? Is it tachycardic? All of these things we'll be looking at. So the first thing you're going to do when we're suspecting is do just a simple EKG, seeing what, is there cardiac dysrhythmias. We can see hypertrophy of ventricles in there as we get into 12 lead EKGs. You don't have to do that, but I'm just saying it's something you can see. An echocardiogram looks at blood flow going around the heart. Once you find a problem or a suspected problem on an echocardiogram, get those parents prepared for a cardiac catheterization. They need to go and investigate further. So that's that diagnostic cardiac catheterization. Now, sometimes we do interventional cardiac catheterizations. And what's the difference? Well, an interventional cardiac catheterization is when you can go in and fix a problem. We actually, at Nicholas Children's Hospital, are one of the first people who put helix devices in, which is this little, like two round circles with a center that goes through the septum, which took care of holes in the heart, ASDs, VSDs. That fixed the problem, right? Or it could be you're having tachydysrhythmias. We can go in and find where that pacemaker of the right atrium is not where it should be. It should be the SA node. Sometimes in other places, I want to work today. Let me use me. And of course, the right atrium or atrial heart rates are really high. So we're going to see tachydysrhythmias up and down, and we can zap that little point and stop those things. And that's usually your electrophysiology studies. It goes in there, finds out where in that heart wants to do something it shouldn't, and we zap it and say, no more, stop doing that. Let the SA node do its work. So now we're in a cardiac catheterization. Number one, preparing the family and the child. These children will get big catheters inserted in their right femoral artery and vein, and they will go in, inject dyes, and they will find out where in the heart is going on. Now, these children should be having clear liquids up to 4 hours before, and then within 2 hours before we should have them NPO so that they're not going to vomit. During cardiac cath, they will intubate and sedate these children so they're not knowing what's going on. Adults, they'll just sedate them with propofol or something, but with children, we do knock them out so they don't move. Now, your child comes back from a cardiac cath. The first thing you do is check that dressing. Can you imagine you have a vein about that big as a femoral artery in even little infants? Let's say the clot from that where the catheter was pops off. Can you imagine how much blood can come out there, how quick? And it can bleed out extremely quick. What happens if you find that that is coming out quick? You put pressure above the site, closer to the heart. So if the little hole was here, above it, you're going to put 2 fingers and put pressure, and of course call for help. But the treatment is holding it till the blood stops. And older children will put sandbags on there. Now, these children must maintain on bed rest for 24 hours because we don't want that clot to bust off, which means bedpans for older children, and of course diapers in younger children, just like they are. And that leg cannot be bent. If they're in physical therapy, tell them to get out. You're not going to do exercises on that child. Parents can hold their children, but they have to keep that leg flat because we don't want it bent, okay?
With
Now,
adults, they can go through the wrist. Do they not go through the wrist with the children?
no, they don't. Only going through the groin. Never ever seen in the wrist. Never. So vital signs, we'll take vital signs. Also, we're going to be checking pulses in the lower extremities. Now, because of the threading of the catheters, they could be slightly decreased, and that's normal, as long as they have good perfusion, like they should, and making sure that we pass that on and report to the next nurse so they know that there was slightly decreased pulses there. They can be slightly elevated, their head slowly, okay, not quickly, because you don't want to burst that clot off and create a bloody mess. And we will be giving them IVs. They can drink, they can eat, not a problem at all afterwards. And we do check blood glucose levels because children can either drop due to stress or elevate due to stress. So we do watch blood glucoses very carefully post-catheterization. Now, congenital heart defects, I never knew there were as many as they were until I started working in the cardiac ICU at Nicholas Children. Got a surgeon in from Boston, Dr. Burke, who's just the most amazing man and the most appreciative physician. Always would tell me every morning, thank you, Betty, for all your hard work. Great job. And there's not too many cardiac surgeons who do that. And it made you want to work there more because of him. Because let me tell you, you work hard with these children. Now, this is the major cause of death after prematurity is congenital heart defects, although they're getting better and better. Most common is a VSD, ventricular septal defect. All it means is a hole between the right and left ventricle. Atrial is between the atriums, atrial septal defect. And we know many, many Downs children, the one thing we are concerned about is cardiac defects, usually VSD. There's 2 other things, but usually AV canal truncus, but usually it's a VSD. When you see this little kid and all of these tubes hanging out, this is exactly what they look like. They do have these tubes hanging out of them. There are intercardiac wires. You see those little blue things that are all curled up there. There is your chest tubes, 3, 4. You have all sorts of atrial lines. They are a very intense little 7-pound little patient that you take care of. So in heart problems, congenital heart defects. Some, they perfuse, they've got oxygen, so they're acyanotic. Some, they're very cyanotic. One of the heart defects, the major heart defect that you will see for a cyanotic heart defect is a hypoplastic left heart syndrome. And all that means is that left ventricle is thick, muscular, and it doesn't work. So you're not pumping blood around. So that's a big thing. Also, tricuspid atresia, because now you can't go from the right atrium to right ventricle up into the lungs, can you? So that's another cyanotic one. Now, one concept in cardiac is what we call shunting. So I made it clear that the left side has higher flow, higher pressure of blood moving than the right side, correct? If I had a hole between the two atrium, okay, we know patent foramen valley, all infants have at birth, but some of them keep open and then it's called an ASD. Where is the blood going to go shunting? From the left atrium to the left atrium, the left atrium to the right atrium. So you'll have increased pulmonary blood flow because you're just recirculating a lot of blood, aren't you? So increased blood flow is from the left atrium to the right atrium, an ASD, and goes up into the lungs. It's going to be increased blood flow into the lungs. So if I had a VSD, again, left ventricle to right ventricle, because right, the blood just goes in, left ventricle is pumping, that left ventricle motor is going, it's going to go, and again, it's going to go up and increase pulmonary blood flow. Does that make sense? It's a hard concept. Shunting. How does it go from one side to the other? Well, we're going to keep going. All right, here are your diagnoses, and let me tell you which ones are of importance. Ones that you're going to see, I'm not going to overdo you on these. So didn't I just talk about increased pulmonary blood flow, right? You have a heart. You have a hole between the two ventricles. Did I tell you the left side has higher pressure flow than the right side? So the right side can't fight to keep that flow out. So the left flows into the right side. Make sense? So if you have extra flow going into that right atrium, it's still going to follow the same path of the blood flows back into the lungs, increase pulmonary blood flow, whether it is an atrial septal or a ventricular septal defect. Now, I want to do something right now. Let me come off of this. I want to go into this. You have a heart. You have your chambers. You have your aorta coming off. We know that the right side goes up and it goes into lungs, right? These are pulmonary arteries. There is something that infants have that we call fetal circulation, and that connects the pulmonary artery to the aorta. That is fetal circulation. It keeps unoxygenated and oxygenated blood, keeps it mixing, right? At birth, this thing is called a patent ductus arteriosus, short PDA. Now at birth, within 21 days, it closes. And if it doesn't close, remember, left side has a lot of blood flow, right? It's going to keep shunting back up to the lungs, isn't it? Because whoosh, that engine is pushing. The pulmonary arteries come from the right side, so it's not going to be as higher pressure. So PDA, patent ductus arteriosus, fetal circulation, present at birth, is going to put more flow going up into the lungs. This is another one. Now, sometimes when we don't have mixing of blood due to congenital heart defects, we want to keep this thing open. And there is something naturally in the body called prostaglandins. It's a hormone, prostaglandins. And if we need to keep that open, we're going to put them on something called prostaglandins. Now, sometimes this is something that doesn't close and we don't need it. And this creates a murmur, big murmur, because it's flow and flow and flow going on. And it's creating mixing of blood that doesn't need. It's making the heart work more than it should. So we need to close it. And we can do that with a medicine called indomethacin. These are two medicines you need to know. Indomethacin medically closes it, and prostaglandins keeps it open. When do we want to keep it open? We're going to go into that next. Okay. Another thing that's an obstruction, we've already talked about it, is coarctation of the aorta. So remember, wherever the obstruction is, the blood flow goes backwards. If the aortic valve is not open enough, blood's going to go back to the lungs. If the pulmonary valve isn't open, stenosis is narrowing. Atresia is nothing. There's no valve. So stenosis is a narrowing. So aortic stenosis is like a coarctation, but down on the valve. So blood's going to go into the lungs. Pulmonic stenosis, it goes into the lungs. So it's going to go backwards and go back to the body. Usually your liver gets all full because you can, where's it going to go? So that's where that goes. Then we have cyanotic. And the one diagnosis that you see, I've been told that the NCLEX loves it, is called tetralogy of Fallot. Tetralogy of Fallot is basically a pulmonic stenosis. And it's like an intermittent stenosis. It literally takes, there's a flap of tissue. So you have your pulmonic valve going to the lungs. A flap of tissue all of a sudden goes over it and covers it. So there's no blood flow going to the lungs. This is what we call a TET spell. In an infant, how do we treat a TET spell? Well, thank goodness we have abdominal pressures and we have chest pressures. And we could take and put this infant knee to chest quickly, and it changes the pressures in the chest, and it will take that flap off and allow blood to flow. Later on, these are all repaired surgically, but initially we can do that. Older children are pretty neat. What they do is, and there are some kids that could be 2-3 years old with tetralogy that didn't know it. You can have them just naturally, they'll just squat on the floor. All of a sudden they'll be walking, they feel funny, and they'll go right down onto their, their butt to the floor with their knees up in the air, squat. And again, what did that do? It's like knee to chest, and they take care of themselves. Now, transposition, cyanotic, transposition of great arteries. The aorta and the pulmonary artery are switched. So the right side goes to the body and the left side goes to the lungs. So you're not mixing oxygen with the body. So how are we going to oxygenate this child? We're going to keep that PDA open because now that's going to mix it. This is the one that we are going to put this child on prostaglandins. The prostaglandins is going to keep the oxygen going to that baby. And then the other thing, as I said, hypoplastic left heart, probably the most severe. It's a multi-surgery thing where we need to put as much oxygen as we can. These children at birth, normal O2 saturations can be 65 to 75. And as long as we have that much going on, we're happy actually with it. So this is something that you're just going to have to look at, read it, try to understand it. And if not, come to me and I'm going to show you some more. So there's a lot of things that I've showed you, and there are all of these things here. All right, so you know a couple of the defects now. We know that there's coarctation, which fills up the lungs. We know that there's transposition, where there's no oxygen going to the oxygenation. There's, they're not mixing, so we keep PDA open. We know there's tetralogy, where it doesn't let blood go into the lungs, so no oxygenation. Knee chest quickly to get that child oxygenated. I've actually seen O2 sats go from 100 to 10 in about 15 seconds flat. Kid went from pink to black. Knee chest, knee chest. It was scary. Okay, now congestive heart failure. Congestive could be right or left side. Sometimes the right side could be not working well, and it can cause flow to go into the lungs, and it doesn't allow blood flow to move around. So what is congestive heart failure? Well, the heart pump's just not working. Blood's not going around where it should. So it sort of sits there, and a lot of times the blood will fill up into the lungs. What is this kid going to look like? Well, this kid is going to be full of fluids. It's going to be now full of fluid lungs. That means they're not oxygenated. So what are you going to see? You're going to see a child who can't breathe. You're going to see them tachypnic, decreased breath sounds. We're going to see the color poor, decreased oxygen saturations on a kid with congestive heart failure. One of the ways, if we know, for instance, if you have a coarctation, possibility of congestive heart failure is going to be right there, right? Because we know blood's going to fill there. How do we know when an infant is going into congestive heart failure? Well, they're saving fluids, collecting it. Heart's not beating good. So you're going to have a decrease in urine output. That urine output, I mentioned it last week, but I'll mention it again. How do we measure intake and output on an infant? Well, it's 1 ml is 1 gram of diaper weight. Number one diapers weigh 30 grams. You take it off the infant, it weighs 60 grams. You had 30 mLs of urine output. That's why cardiac children, strict intake output is very important. Because if we start seeing them gaining fluid, we can give them something like furosemide immediately and get that fluid out of them, right? We can prevent problems. So our goal, as we're watching this, is to prevent that accumulation of fluid in there, which will improve the cardiac function, give them some medications to help the heart beat a little bit better. We're not going to have that kid, feeding, probably NG tube, OG tube, because of course nutrition we want them to have, but we don't want them to suck, swallow, and breathe, because that's really hard. And we're going to probably put some oxygen. We're going to make it easier for that child to breathe. So improving the function, we're going to make sure that urine output's there. The most important thing with I and O, not only measuring the diapers and what's going in, is daily weights. See, daily weights start going up too fast. Again, we know it's accumulation of fluids. We know nutrition's important, so they need to eat. So giving them nutrition, but monitoring them very, very closely. One of the things with infants, and you start seeing them in respiratory distress, there's two things that scare me. When I see nasal flaring and I see an infant grunting, it's like their nasal are flapping, flaring, and then you're after each breath. That's a grunt. When I see an infant grunting, I bring them immediately to the trauma room. That child is about to code. Grunting on an infant is severe respiratory distress. Now, you have a child who's cardiac, who's in trouble, always, that poor mother, she's hormonal, just had an infant, and support that family completely. So hypoxemia is something that happens in cardiac conditions. Remember I told you about the hypoplastic left heart, that you could have O2 saturation 65 to 75. It's normal, right? Well, what does the body do when you don't have enough oxygen? It makes more red blood cells to carry more oxygen, right? But there's still no oxygen to carry, but you've got all these red blood cells. That's why they become what we call polycythemic. A normal hemoglobin hematocrit could be what, 14 and 42? They could be 18 and 54. I'm serious, their hemoglobins go really high. It's the body trying to help, but there's no oxygen to carry around due to the hypoxemia, due to the cyanosis. And as you can see, this is an older child, probably with a hypoplastic heart, right or left, doesn't matter. And you can see the clubbing, what's going on. Looks like adults, but it's in a child. Remember, we put oxygen on children because we want their oxygen to be as normal as possible. So again, when you have a cardiac child, these children are probably going to be a lifelong care for these parents. We really need to help them understand what this diagnosis is and how to take care of them, knowing and preparing them. What are they going to look like after cardiac surgery, cardiac cath? What can they do? What can't they do? I mean, if that child, let's say, and I've done this many times, kid comes back, open hearts on CPS, still from the the heart lung machine right after surgery, they can't get them off. I'll have them comb the baby's hair. I still want them involved in their care, or wiping their lips off, or wiping their eyes off. Keep them involved in the care, because I'm telling you, infants are the strongest of all humans ever made. They tolerate so much, and that's what I love working with cardiacs and with infants. They amazed me every day I worked with them. So always be teaching, keeping parents involved, and you always plan for discharge right from the moment they walk in the door, because they're going to have to be taking care of this child at home. These cardiac children are always born to the most amazing families too. Endocarditis is a bacterial infection, could be due to many things, just like adults. We're going to give prophylaxis, just like adults, no difference in it. Rheumatic fever. Rheumatic fever is something that is caused by an undertreated strep throat. There are two conditions in peds you need to be concerned about due to strep throat. The first one is rheumatic fever. What you will see is a rash. You'll see the joints swollen, fevers, and they're all going to feel horrible. And when we hear all of these things, we'll ask, has your child been sick lately? And if we hear that they've had a sore throat, we're going to suspect rheumatic fever. And we treat this with a long-term antibiotic. So whether it's IV or oral, they keep changing their minds. They used to only do IV. Now they're, doing research on just doing the oral, which one works the best. I mean, it's better if we can just put the kid on oral antibiotics than having a PICC line sending them home. But if we do not treat rheumatic fever, it will cause permanent heart valve damage, and will end up having this child become an older person who needs a valve replacement. Children do get high fat too, believe it or not. So we are checking them now for cholesterol. We didn't do it before, but now we know that there's some sort of familiar type of reason for them. Children get slow dysrhythmias, fast dysrhythmias, PVCs. They get all of the things like adults. It's no difference. And we treat them with the same medications. Mics per kilo per minute, milligrams per kilogram per minute, per hour, per dose, whatever. It's the same medications. How would you know if you had a child who was placed on digoxin? How would you know of possible ditch toxicity? This infant's 2 months old. They'd be vomiting. So knowing that vomiting is one of those side effects, digoxin, I'm about to give it, even if the heart rate's okay, I'm going to hold it, call the doctor, and I'm going to get a level. Because vomiting can be the only thing you see in an infant. So in infants, you really got to think. You really got to say, what could that be? Pulmonary arterial hypertension is when those lungs just stiffen up due to some, reason. It could have been that acute lung injury where they don't like to oxygenate, and Pulmonary arterial hypertension, usually these children end up with lung transplants. You will see them really hard to breathe. Of course, syncope due to hypoxemia. I've seen young school-age children have to have pumps with medicine on a continual basis on these things that they have to use until they can get their lungs. Cardiomyopathy, as I said, it could be that viral one, could be infectious, could be lupus, could be anything, that collagen vascular disease, and we'll support it as much as we can. But again, transplant is the thing that we do. And the problem with transplant, is rejection. They do reject, and that is the big thing. They do need to be on anti-rejection medicines for life. I've seen several of my hypoplastic left heart syndrome kids that I've followed for the last 20 some odd years. Some of them get heart transplant. In fact, Valentine's Day will be Thomas's 11th year with his heart. He was a hypoplastic left heart, and on Valentine's Day, he says, "Mommy, I'm getting my heart today because it's heart day." And at 5 o'clock in the morning, they woke him up and he got his heart. And that kid, he has 3 brothers with him, great family, and he's lived a beautiful life because he's gotten a heart. So heart transplants work. I just had last year, another girl who had a heart transplant went in for a second and it failed. And the mother sent me the most beautiful letter in Facebook, actually, to let me know that they thought of me all the time, that they remembered how I gave care. This is my little Olivia. And that they always told the nurses about me, and that to help them understand things more because of what and how I had taught them. So you can touch people for life as a nurse. And, I hadn't seen this girl in 10 years and I'm still getting my Chris, another one who died at age 25, my daughter's age. So this is now 13 years ago. Every single nurse's week, it's from his mother to Chris's favorite nurse. Happy nurses, you will always be his favorite. So you make difference, you do. And we are now treating hypertension earlier. We used to not do blood pressures on children, like they don't get hypertension. Well, now we do 2 and 3-year-olds. We will check blood pressures to be sure because they can get them. Kawasaki disease is not a motorcycle. It is a disease where it's called an acute systemic vasculitis, or inflammation of vessels. The vessels get swollen and they tend to get big out, they're going to burst, they're going to rupture. The one vessel we're the most concerned of is the coronary arteries. These children start out with an upper respiratory. It's one of these long diagnosis things. Upper respiratory, placed on antibiotics, still not doing well, many times up to the emergency room, and we'll start seeing a little peeling on their hands, which is your sign, the rash. But when you see these glow in the dark red eyes, this is Kawasaki. The big thing with Kawasaki is it's a viral infection, but we are concerned that we are going to have a blowout of a coronary artery, which could kill these children. So how do we treat these children? Well, in Kawasaki, we give intravenous immunoglobulins, so IVIG. So it's basically a virus, but we also give them only time aspirin. And the aspirin is an anti-inflammatory, but it also stops little clots. Because if you have coronary arteries with little clots going through, it could go up into the head, into the lungs, and et cetera. So it thins the blood, prevents clots, and decreases the inflammation. It's usually a 1 month long type of treatment, but usually you have it once and you're done. You don't get it. The chief cardiac, the head of cardiac ICUs son at age 3 had Kawasaki disease. And that's how I learned about Kawasaki. Shock can happen due to many different reasons. And what do you see with shock? Well, it's usually your respiratory goes down, heart rate up, blood pressure down. And it could be due to many different things. Some children can compensate, some can't. We know anaphylaxis and of course, overwhelming sepsis can cause it too. So here's a question about that ductus arteriosus, your PDA. So remember, this is a tube from pulmonary artery, goes to the aorta, so it can give blood to the body, right? And then the aorta goes back into the lungs too. Now, surgical closure of the ductus arteriosus would cause what? That connection now is gone between the pulmonary artery and the aorta.
Prevent the return of oxygenated blood to the lungs.
Ding, 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 ding. Yes, it is. Good job. That's a hard one. That's a hard one. Good job. All right. Any questions? A lot of stuff going on there. This is a big, I'm telling you, it's a big one. Now, there's other things to do with respiratory. It's going to be on your Kahoot. So let's get that going. And we should be just about on time today. I hate to keep you guys over because I know your time's important. Hold on. Now there's a new questionnaire out there for y'all, survey. I know you get them like crazy, but it's appreciative if you do. Fill them out. We've been asked to tell you. So if you can fill out your surveys, I'd appreciate it. I know you're busy. I mean, the one that I always get all the results from is the final one. So you can tell me, what can I do better or what do you like? That's what I need to know so I can help the next group even better. That's what nursing is, helping the next person. Can you tell I like cardiac just a little bit? It's a hard one. I hope I explained it enough for you to be able to listen to it again and say, okay. If not, get a hold of me. Here we go. Respiratory, cardiac system.
Can I have the Kahoot to play?
Do you have it?
Are we gonna have them?
Yes. A majority of upper respiratory infections are caused by what? You know, I forgot to send you last week's. I will be sending it. I truly sorry. You'll get both. Upper respiratories, what are they caused by? Children get them all the time. And we know it's viruses. Remember, most of the time they're viruses and we don't even call them bacteria yet. And Kristen went up top first. She was quick to the draw. What would you suspect if a child has a dry, bothersome cough that keeps them awake at night? And that's probably your croup, okay? And as I said, you'll see this at night and then you'll see them barking, 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 barking. Asthma, it doesn't mean nighttime. It could be any time of the day. The preventative immunization for RSV is which one? Now I gave you the generic name. And it is called Synergist. And it's also a MAB, okay? It is, you know, to help the body from fighting against it. Humira is for RA. Hib, it's your hepatitis one. That's completely different. It's not for a respiratory syncytial virus. All the following are signs of early respiratory distress in children except. Remember I told you that late is going to be nasal flaring and that grunting, especially in the infant. What are you going to see up to that point? You're going to see, now, if you're in respiratory distress, you're going to see the heart rate go up. You're going to see the respiratory rate go up. You're going to see them get really restless, right? From hypoxemia, anoxic, you're going to see those things. Bradycardia is late signs. That is when the kid's going to code. You're not going to see bradycardia on until they are that ill. A 4-year-old has been taking meds for asthma. The child's still wheezing. What information is important? So if you have a 4-year-old who has asthma and the mom says they're taking their little aerosol, you can ask them, are they using a spacer? Do they know how to use it? Because it can just be spraying it in the air and they're not getting their medicine. So that's a key information to understand. It probably will prevent even an admission to a hospital if they're at that point. An 8-month-old with croup exhibits what signs and symptoms of respiratory distress? An 8-month-old. You know, you're going to be surprised. Many of these children, you know, have been barking and coughing like crazy. They're still going to hold their O2 sats at 100%. Respiratory rate of 25, that is way too low for an 8-month-old. Abdominal breathing, not necessarily. It's that retraction and the restlessness, because remember, this is a swelling of the airway. They're probably becoming more and more hypoxic. Respiratory distress, that's hypoxemia. And Dina's on fire. Signs and symptoms of asthma include all except so you're going to have the cough, you're going to have shortness of breath, wheezing, but it's a prolonged expiratory phase. They can get air in, but it comes out, it goes in the end. I literally, did you hear that little tiny squeak? You will hear a breathing out and then you hear in the end, because they all tight. They can't get air out. They can get it in, they can't get it out. That's asthma. Signs and symptoms of congenital heart disease include all except. Well, remember, when you have congenital heart disease, it means the heart's not pumping blood correctly. So that heart is working really hard, isn't it? So you're going to see them tire out easily. You're going to see them feeding poorly, tachypnic, tachycardic, but they're not going to be gaining weight because they're burning calories just beating their heart. So you're actually going to have a lower heart rate. You're going to have usually failures to thrive. What would you not do to children diagnosed with croup and epiglottitis? Remember, croup is that upper respiratory laryngobronchial tracheitis. Epiglottis is the epiglottis is swollen, covering trachea. What are you not going to do unless you know how to intubate? You're not going to look inside their throat because you can create more swelling there. And they say that if you are looking inside, you better be that person who can intubate or start a trach, okay? Doing a soft chest tissue x-ray, you're going to see the swelling. You're going to put in an IV because you need to give the steroid most of the time. And a child is a much happier child if they're in the parent's lap. So the stress and the breathing is going to decrease and they'll be more comfortable. Epiglottis is what? What is an epiglottis? So the epiglottis is that leaf-like cartilage that prevents choking because it covers the larynx when you swallow so that you don't get aspiration. Yes, when the epiglottis is swollen, it's covering the larynx. You can't breathe. You'll see drooling and severe respiratory distress. Tripod position, drooling is one of the key signs. Multi-select. When doing an admission on an infant with a low-grade fever and a loose cough, what information is important? So you're bringing this infant into the hospital. And you need to do your nursing assessment, your history. So we want to know the fever. We want to know when the medications, what was given, so I know what I can give next. And are the immunizations up to date? I mean, first of all, Apgar scores at first are not as important. As a nurse, we want to know immunizations, high fever, and then the medications. What is cystic fibrosis? A cystic fibrosis is passed from mother and father to children. Many times it's boys. And again, this is where there's this overabundance of mucus in the respiratory and the GI system. They cannot digest it. And cystic fibrosis is a lifelong battle where parents must be doing vigorous chest physical therapy and aerosols and preventing clogging of the lungs so they can breathe. Also, these children will be taken a medicine, pancreatase is one of them, that we give so that they can help digest their foods. It's lifelong. And if you have one child, you can have more than one. I had one family who had 3 boys, cystic fibrosis, and one of them had a congenital heart defect. Those parents were constantly doing aerosols, constantly helping those children breathe. What is the greatest risk for an infant having a cardiac catheterization? So remember, once you have a child who has the echocardiogram, shows some defect going on, they're going to be scheduled for a cardiac catheterization. So get the parents prepared for it. The biggest thing is bleeding. Remember, they can bleed their whole blood supply out extremely quickly. And it's the first thing I'll always do. Let me look at that site. Because in moving the child back to the room, they could dislodge that clot that they had already formed. And many older kids, as I said, will have a sandbag there. How is cystic fibrosis identified? So we know that cystic fibrosis, sometimes infants are born and they're constipated at birth, which isn't normal. One of the tests we'll do, it could be cystic fibrosis. Or we know familiar history that there's a possibility. And literally, if you licked this child, you would taste salt. Now, I'm not telling you to lick another person's child, but if you did, if it was your child, you would taste salt. And it's a basic sweat test that they do, and they look for salt in these children. And that is what identifies cystic fibrosis. Don't lick kids now. I didn't say that. Dina's still on fire. A multi-select. What's included in the plan of care for a child with cystic fibrosis? So again, aggressive chest physical therapy, they need good protein. Now, remember, they're losing salt, so you don't have to put them on a low sodium diet, okay? Remember, if they're losing salt, you don't put them on a low sodium diet. And of course, pancreatase with meals. Usually it's a half hour before meals or with meals, not 3 hours before, not after. With meals, you're gonna be giving the pancreatase. Now, you can open these capsules and you can sprinkle it on their food for the younger children. But remember to rinse their mouth out afterwards, that they brush their teeth after they eat, because it can hurt their teeth, okay? There's a question on your NCLEX questions that you'll see with that. What is the drug of choice for pharmacological closure of the PDA? I wrote it down for you on the whiteboard. And the crazy thing about this drug, it's like a NSAID. It's like a Motrin. It was used as a pill form for back pain many years ago and still is. But it's called indomethacin or Indocin. And it is given to pharmacologically close it. And there's a process that goes with it. Because it's a SIN, it affects kidneys, just like the aminoglycosides. And they can close it medically, and they always try. They'll try 3 rounds. If it doesn't work in 3 rounds, they have to do a surgical closure for it. Aminophylline is used for breathing, and meloxicam is actually another painkiller type thing. We don't use that. I've seen it used in animals too. Dr. Pohl said so. Which is not a feature of tetralogy of Fallot. Now, tetralogy of Fallot is all right side. It has to do with something that obstructs the pulmonary artery, so blood can't get up there, okay? So if blood can't get up into the lungs, what happens to that right ventricle? So aortic is left side. Yes, excellent. Pulmonary artery stenosis. Usually there is a hole between the ventricles. And you will also see with these children, because the blood can't go up the ventricle, the right side stretches. There's also one more thing called an overriding aorta, which means the aorta just moves over a little bit. But those are the 4 things. But remember, always right side. Tetralogy, right side. What medication would you hold for an infant that's vomiting? And the vital signs are 98, 88, 32, TPR. So, I mean, the pulse sort of gave us the clue, but remember, vomiting infant on digoxin, don't ever assume it's just regurg. Make sure you check that digoxin level, especially with a decreased heart rate too. Why would a child with tetralogy of Fallot not gain weight at the normal rate? I mean, what does tetralogy do? It blocks off the oxygen, and they have periods of hypoxemia, right? And without enough oxygen, you have no energy, right? You become restless. You can't do what you need to do. Very good. All are examples of cyanotic heart murmurs except which one? Remember, atresia is no opening. And I'll tell you, it's not truncus. Everything's just wide open in that, no valves anywhere. So all examples are except aortic stenosis. Remember, stenosis is still an opening. Blood still is flowing to the body. It's just decreased. Many times they'll just go in, they'll balloon it in a catheterization and open it. But stenosis is still moving. We know tetralogy is definitely cyanotic. Remember, 100 to 10 in 15 seconds. I know TUSAT went for me. I'll never forget Nathan, and his name was Nathan. What is the most common cyanotic congenital heart defect? So one I told you, you need to know for your NCLEX. Where I took my NCLEX, I would definitely review this condition. Tetralogy of Fallot. PDA is not cyanotic. We are putting oxygen from the lungs to the aorta. And hypoplastic left heart syndrome, thank God it's not common because it is a 3-stage surgery, multiple cardiac calves. It's a really long-term care and it usually ends up in transplant. It is that tetralogy. Nursing care following a cardiac catheterization. Again, you're going to check that dressing first. Number one, check the dressing and then do the rest of your vitals and assessment, etc. Nursing education for cardiac catheterization include all except so remember, you will never bend that extremity. And why? Because you could pop the clot on the catheter insertion site and cause bleeding everywhere. You need to know allergies. You need to monitor vital signs, and you need a pressure dressing there on the area where those catheters were. You will not bend that extremity. You will not put it on a pillow. You will not get them out of bed till the next day. Which important information is most important when rheumatic fever is suspected? What is rheumatic fever caused by? What's the first question we ask when we see fever, rash, joint pain, malaise? Have you had a sore throat recently? Very important thing. There's something called an ASO titer. It's an anti-strepolytic titer, and it measures strep in your body. If this child had a positive ASO titer, you will know that it was due to a strep infection that caused rheumatic fever. And then how do we treat rheumatic fever? It's going to be about a month-long, long-term antibiotic therapy. Signs of shock in children include all of the following, except so we know in shock is the elevated heart rate, decreased blood pressure, poor capillary refill, decreased urine output, altered mental status, hypertension, we wish. No, the blood pressure falls down and needs usually to be supported through medications. And inotropes like dopamine or dobutamine or epinephrine. What is the treatment for Kawasaki disease? And remember, it is a systemic vascularitis where we are concerned about aneurysms in the coronary artery. And one of the treatments we'll be doing is doing an echocardiogram looking at those coronary arteries to make sure that they're okay. We give aspirin because why? Aspirin thins the blood. It's also anti-inflammatory. And then the intravenous immunoglobulins helps the body fight the viral infection. It's both, not just one, both. Which of the following best describes the pathophysiology of Kawasaki disease? I just said it. Multi-system vascularitis that may affect the coronary arteries. And that's what we are most concerned about because we don't want an aneurysm, and that could, if it bursts, the kid would die. Multi-select. A clinical manifestation of Kawasaki disease is, and it's not the motorcycle. So we are going to see those blistered or cracking of the fingers, palms, of the soles of the feet and the hands. The tongue does get all red and strawberry, those big red eyes. I'm telling you, I've never, it looks like you've been in chlorine for days. I mean, they are red, 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 red. Really, there's this erythema margium. It's a very small, fine rash. You don't see the big blotches of a rash. It's a different type. Dina's been on fire all day. Why is an echocardiogram needed for the patient with a Kawasaki disease? And because we're looking for coronary artery problems, and we're really looking for that aneurysm. Thank goodness the director of the cardiac unit, the head of it, his son didn't have any coronary artery problems. In fact, he's playing minor league baseball right now. It's doing good. Which of the following is the most common cause of shock in children and infants? Most common, what would you think? It's infection. Infection is the biggest thing. Kids get infections, their bodies can't handle it, becomes overwhelming, and their heart starts giving up, and they go tachycardic, their blood pressures drop, and they need good antibiotic and good cardiac support, inotropes, etc. What are the defects associated with tetralogy of Fallot? Remember, tetralogy, right side. So, pulmonary artery stenosis, ventricular septal defect, the misplaced aorta, like I said, and then the right ventricle hypertrophy because it stretches because blood can't flow. When you look at the other answers you put, the pulmonary artery and aorta switched is transposition of the great arteries. And the other one has left ventricular hypertrophy. It's right-sided, not left. And Kristen went on fire now. A young child with tetralogy of Fallot may assume which position naturally when having a TET spell. Well, we know infants, they have a TET spell. We're going to do a knee chest quick because it changes the pressure between the abdomen and the cardiac areas, and it will force the pressures to change. And what they do is they just squat down and it's doing the same thing. It's doing a knee chest by themselves. Transposition of the great arteries is which? I just talked about it. Again, it's when the aorta and the pulmonary artery are in the wrong position. So you have systemic blood, which is unoxygenated, and then you have the pulmonic, which is totally, and they're not mixing. So you're not getting oxygenated blood to the body. So what do you need? You need a PDA open. How do you keep a PDA open? Prostaglandins until they can do an arterial switch operation. Which of the following is not an intervention indicated for transposition of great arteries? So oral anything is not going to work. Now, let me tell you why they do the balloon atrial septostomy. Well, you're doing many things to try to get the mixing of blood. So if they take that patent foramen ovale, right, between the right atrium and left atrium, they take punch a hole there called a balloon septostomy. It'll allow, again, blood, oxygenated blood to mix, and it helps the blood mix around. And again, the arterial switch is what the surgery is called. They pick it up, turn around, put it down. And these kids do very well, very well. Multi-select. Why is prostaglandins given to a child with transpositions of the great artery? I think I've said it at least 3 times already. Well, where is prostaglandins naturally in the body? At birth, the prostaglandins is what keeps the PDA open. And that PDA open keeps the mixing of oxygenated and unoxygenated blood. So it helps with oxygenation and it maintains that output. So we keep the blood flowing oxygenated to this infant until we get to surgery. These children are on a prostaglandin drip. Many of them, they're not intubated or anything. You can orally feed them a bottle, even breastfeed if the parent wanted to, until we get them 7 to 10 days out. And under a very relaxed time, we'll do the switch operation. These kids do good. What is the purpose of giving indomethacin to a neonate with a patent ductus arteriosus? You know, many premature infants have patent ductus arteriosus that don't close by themselves. And for some reason, they keep producing prostaglandins, which keeps the PDA open, which creates this big murmur going on, and it makes the heart weak. So indomethacin stops the prostaglandins, says, don't do that no more, and it lets that with just chemically will close the duct, and it doesn't there's no surgery that will be needed to be done. So indomethacin closes the PDA. How does it do it? By stopping the prostaglandins that the body has naturally in it. Where is the PDA located? I've said it about 6 or 7 times now. It connects what to what? Again, it's fetal circulation. It connects the aorta to the pulmonary artery. It allows the body to be oxygenated. When you close it, it just keeps the oxygenated blood going to the body. This heart defects allows blood to pass from the left ventricle to the right ventricle. What is that called? And it's called a ventricular septal defect. Well, what other heart defect allows blood to pass from the left atrium to the right atrium? Arterial septal defect, okay? It's just a hole. There's a septum in the middle. It's just a hole in the septum. And ash is on fire. A multi-select. What is a sign of digitoxicity in infants? You'll see a low heart rate and you'll see nausea and vomiting. Now, what infant's going to tell you that they're seeing yellow spots? They're not. It's going to be an older child. So nausea, vomiting, and decreased heart rate are what you're going to see. Now, are they seeing yellow spots? Well, they might be, but they can't tell you. Where does the blood go when the ductus arteriosus closes? There's actually 2 answers that are good here. It either goes back to the body, back to the lungs, but it's not mixing anymore. It's not going from the aorta back up to the lungs to reoxygenate it, or from lungs to the body. Nope, it's where it should be now. What is congestive heart failure? Congestive heart failure is when the heart can't work good enough, not squeezing good enough, fluid builds up in the lungs. What are you going to see in the infant? Weight gain, decreased urine output. You're going to see them start getting tachypnic, tachycardic, retracting, lack of activity, unable to finish a bottle, just tired easily, hypoxemia. All of those things you can see in congestive heart failure. You see failure to thrive too, because they're not eating, because they're tired. Left-sided congestive heart failure causes what? Where does the left side go? Backwards into the hose. So it's like the coarctation goes to the left ventricle, left atrium, and up into the lungs. And what do you see? All the above. Good job. A multi-select. Signs and symptoms of rheumatic fever include Now, one of the things that I didn't talk about is something called chorea. Chorea is the shuffling of gait that you will see. As you treat the rheumatic fever, it will correct itself. It's usually in the falling over with all of the rest of these pains, which brings the parents with the child to see the physician, but it does get reversed. So it's chorea is part of it, but it's all the above: the rash, the arthritis, the nodules, etc. After a heart transplant, which is a leading reason children die? I think I spelled that wrong. It's rejection. Rejection is the biggest thing. A multi-select. A child is about to have a chest tube removed. What should you do? Now, you know, chest tubes are, especially after cardiac surgery, you've seen the pictures, it could be 2, 3, 4 of them. And once they stop draining, they take them out. Now, explaining on their level is number one. Medicating them for pain because it burns and it hurts. Also, these chest tubes, many of them go into the lungs. So you want to have their bed elevated so they can breathe. You're going to place them laying down? Absolutely not. You want them up so they can breathe. Makes sense, doesn't it? Thinking about it now. A child just had abdominal surgery and cannot cough well enough to expectorate secretions. What is your priority? I mean, we need children after any surgery, abdominal, cardiac. How are you going to make them breathe easier? We want those lungs to stay good. You know, we have incentive spirometres and all of these, you know, pulmonary things that we do. But the first thing that we're going to do is medicate them for pain. Once we medicate them for pain, we can put a pillow over their belly. We can then have the head of their bed elevated, get them out of bed, getting them walking, use incentive spirometry. But without pain medicine, they're not going to do it because they're probably not moving because they hurt, okay? An infant of 3 months has a fever of 103.6. What would you medicate the infant with? A 3-month-old, what are you going to give them? Until 6 months old, all you can give a child is Tylenol, acetaminophen. After 6 months old, you can start with ibuprofen. You never give aspirin and naproxen. Those are things we don't give infants and young children. So 6 months old, acetaminophen, Tylenol. After that, you can add ibuprofen. Something to do with platelet aggregation and bleeding is why we don't give it before then. A newborn infant is assessed, the nurses finds very weak lower pulses. What should she assess next? So you've got a newborn infant, you find those lower extremities got very weak pulses. What are you thinking it could be, and what would make that assessment? Yeah, that's what it is. So remember, weak lower pulses, newborn, a newborn infant, we're suspecting coarctation, right? Weak pulses on the bottom. If we do 4 extremity blood pressures and we find the upper arms at least 20 points higher than the lower, it's coarctation. And now you've made a diagnosis that you can tell the physician. Okay? A multi-select. A critically ill child is on bed rest. What can the nurse do to prevent complications? You know, we have adults and we have children. They're on bed rest, and there's many things we need to do. Just because they're children doesn't mean they're not going to get ulcers and decubituses. They can get them. Foot drop. They can get all those things. We're going to use it instead of spirometry, whichever is appropriate for that child. Pillows and blankets to turn them over to get those right side lungs and the left side lungs, and the head of the bed elevated so they can breathe a lot easier. And we're going to be using some sort of pad to keep them dry, whether diapers for younger children or chucks for older children, and turning them every 2 hours, not every 6, unless contraindicated by diagnosis. A multi-select. How can oxygen be delivered that's easiest tolerated and accurately monitored for infants? So we need to give many times infants oxygen. I mean, with an adult, they need oxygen depending on how much percentage you give them, you know, a mask or nasal cannula. What do we give an infant that they like the best? And it's the oxyhood, okay? We're going to give that oxyhood. It's really good. It's a clear plastic with oxygen. We can give 40% or more in there, and they can suck their pacifier still. Nothing's there bothering their nose. The nasal cannula can be used, but the nicest one is the oxyhood, okay? The blow-by, it's not realistic. You don't know how much they're getting. And, you know, easiest tolerated is not an endotracheal tube. They don't want that. A multi-select. What procedure is used to keep the lungs open with children with cystic fibrosis? Remember, they have thick mucus collecting in their lungs, and we need to keep these lungs loose and open. So deep breathe, cough, chest physical therapy, exercise, and ambulating, not PRN, 2-3 times a day. You want them up and moving. You know, actually, I do things like taking a straw and making little spitballs and having a little target up and having them shoot it. Some of the older kids, this is really good physical respiratory therapy for them. It works. A multi-select. Children with cystic fibrosis require pancreatic enzymes with meals. What teaching should be done? So we know it's right before meals, sprinkle it if you need to, and rinse that mouth. And remember, children do grow and they need bigger doses as they do grow to make sure that they're getting enough. 3 more. What is a cardiac defect where there's no valve between the right atrium and right ventricle? Well, you need to know what valve is there. Right-sided valve between the right atrium and ventricle is called what? And remember, stenosis is a narrowing and atresia is nothing. That's how you answer this question. It's called tricuspid atresia, okay? Tricuspid valve is that valve. If there is no valve, it's an atresia. That's the area that it should be, but it's not. And it's a right-sided hypoplastic heart. What is the greatest risk factor for a newborn receiving a cardiac catheterization? And again, it's that hemorrhage. Good job. And last question, guys. When an infant is breathing fast, tires easily, and needs rest periods during feeding, what should you assess? What do you think is causing all that stuff? What assessment would prove that? Breathing fast, tires easy. This is definitely respiratory. They don't have oxygen. They can't breathe. You are going to be listening to those breath sounds. That's where you're going to see, are they in congestive failure? Number 3 is Meg. Good job, Meg. Whoop, whoop. Number 2, Ash. And number 1, the whole game. Dina. Good job, Dina. Number 4, Carly and TD. Good job, guys. All right, what I want you to do is sign your attendance attestation so that they're done. Don't forget them. Anybody who is completely lost, let me know. I can help you. Try to get you understanding more, draw some more pictures, whatever you need, okay? So thank you very much, guys. Go through your matching, and I think you can see everything's been covered today, and you should be able to have an understanding of it. And I did give you in your on Canvas in the inbox, you're going to see I gave you the answer sheet too. Try to do it without and then try to do it with, okay?
Professor Bogart,
Yes.
Thank you.
I can't sign my attestation right now.
That's okay. I know that. That's fine.
All
That's
right.
fine. You're very welcome, guys. Have a good night.
Thank you.
Anybody who wants to review exam, let me know, okay? I'm taking appointments.